Hello, everyone, and welcome to this RPTH Research Cap, where we dive a little bit deeper into the science being published at our journal RPTH. My name is Johnny Mahlangu. I am an RPTH Associate Editor. I'm a hematologist based in Johannesburg, South Africa. And I'm very much delighted this morning, in fact, to bring this research to you. And I'm pleased to introduce Dr. Nihal Bakir and Ms. Sonia Dover. Dr. Bakir received her medical degree from the University of Jordan, completed her residence and fellowship training at the Cincinnati Children's Hospital Medical Center, where she specializes in hemostasis and thrombosis. Sonia is a clinical research project manager at the Sick Kids in Toronto and is the coordinator of the imaging expert working group of the International Prophylaxis Study Group, which in fact I am part of. They've both co-authored a recent paper published in the RPTCA, the Musculoskeletal Ultrasound in Hemophilia, Results and Recommendations from a Global Survey and Consensus Meeting. And welcome to both Sonia and Nihal. I hope you've had a very good morning.
Thanks so much for that introduction. I'm Sonia, and along with my colleague, Dr. Bakir, we're going to present our work on musculoskeletal ultrasound in hemophilia, the results and recommendations from a global survey and consensus meeting. For persons with hemophilia, optimization of joint health is an important unmet need. Recurrent hemarthrosis continues to be a major cause of morbidity despite recent treatment advances. Hemophilia healthcare providers have expressed an interest in utilizing objective methods for the assessment of joint health and treatment efficacy. Ultrasound, especially musculoskeletal ultrasound and point-of-care ultrasound, have emerged as promising tools to provide additional objective information to clinical assessments, for example, when assessing possible acute bleeding episodes. With that in mind, we had two main objectives for our work. The first was to determine the real-world use of ultrasound in evaluating arthropathy in persons with hemophilia. And the second was to move towards a consensus amongst hemophilia healthcare providers regarding the preferred ultrasound protocols for global adaptation. The first part of this work involved a global ultrasound survey with the objective of determining the scope and use of ultrasound for the management of persons with hemophilia as part of the comprehensive care model at HTCs. And the survey focused on ultrasound definitions and terminology, image acquisition protocols that were currently being used in each center, interpretation of findings and who and what they were doing, and grading or scoring, so whether the images were being graded, scored, or measured. We distributed the survey in the summer of 2018 using an HTC-based approach, meaning we requested a response from only one representative from each center surveyed. Responses are received from just under 25% of the 313 HTCs surveyed, and of those, over 50% reported routine use of any type of ultrasound, meaning either point of care or full diagnostic. There was a high level of agreement in terms of nomenclature to report soft tissue findings, and for which items should be considered for the assessment of the soft tissue domain. The figure here on the y-axis shows the proportion of the respondents, and on the x-axis, the different items in the soft tissue domain. As you can see, a majority of respondents agreed that effusion hemarthrosis, simple or complex effusion, and synovial hypertrophy should and can be considered for assessment in the soft tissue domain. However, there was less agreement on what structures can and should be assessed from the osteochondral domain. This figure shows a breakdown of the respondent opinions regarding what can be seen on ultrasound for the assessment of surface erosions in the top section, subchondral cysts in the middle, and cartilage loss on the bottom. As you can see, there's a wider range of opinions regarding what can and can't be seen, with the highest proportion actually indicating that they felt they did not have the expertise to answer these questions. Finally, we presented a set of proposed definitions for full diagnostic and point-of-care ultrasound that were developed during a prior survey. Most of the respondents agreed with the definitions as written. 75% agreed on the full diagnostic and over 90% for the point of care. However, there were some minor suggestions noted, including that full diagnostic does not need to be done in a radiology department, and that point of care must be defined as an adjunct to a detailed clinical examination, not as a standalone assessment. And we should note that a consensus on these definitions was not achieved during this work.
Part 2 of this work, which I will be reviewing, discusses the findings and the recommendations from the consensus meeting. The objectives of the in-person consensus meeting, which was held in Toronto, Canada in 2018, were to determine the scope of use of ultrasound for the assessment and follow-up of musculoskeletal pathologies in persons with hemophilia. We also wanted to evaluate the global variation in the use of ultrasound. We went on to look into current and recommended future acquisition protocols for achieving the priorities identified above. We also looked into how should ultrasound examinations be interpreted and scored to deliver meaningful clinical and research information. And lastly, we focused on shedding some light into the current gaps in knowledge, recommendations for areas of development and improvement, as well as future directions for research. And all of this is as related to the assessment and follow-up of musculoskeletal pathologies, both acute and chronic in persons with hemophilia. The consensus meeting attendees were 47, and it comprised of persons with hemophilia, hemophilia providers and treaters, and also physical therapists, orthopedic surgeons, and rheumatologists. These, on this side of the pie chart, sat on the clinical workshop. The people who sat on the technical workshop included radiologists, radiology trainees, sonographers, physicists, ultrasound instructor, and a data scientist. The attendees were representative internationally, with the vast majority, about two-thirds from North America, and then the rest from Europe and the rest of the world. The consensus meeting recommendations were divided into high-level summary from the entire group, those from the clinical and technical work groups. When we look at the high-level summary from the entire group, our recommendations were, first, a basic understanding of ultrasound needs to be attained to increase user confidence. Clear definitions of the various levels of ultrasound examinations should be developed. We also recommended that a standardized and harmonized ultrasound scoring system for the assessment of musculoskeletal disease in persons with hemophilia should be developed, tested, and implemented for both clinical and research settings. We did acknowledge that a tiered ultrasound scoring or measurement system that builds in complexity but allows for comparison across tiers should be adopted. And our final high-level recommendation was that future endeavors should include standardization of ultrasound acquisition protocols for detection of musculoskeletal disease in the joints of persons with hemophilia, with a focus on the index joints being ankles, knees, and elbows. Our conclusions were as follows. Ultrasound is a rapidly evolving technology that is gaining traction for assessment of persons with hemophilia. To optimize outcomes, standardized ultrasound protocols should be adopted globally. A tiered ultrasound scoring measurement system allowing comparison across levels is recommended. Guidelines for ultrasound acquisition, interpretation, and reporting will ensure consistency.
It's now my pleasure to thank both of you for the presentation, which was clear. And I would like to ask a couple of questions. The first one is, what is your experience with ultrasound in your center? How does it compare to your survey results?
Yeah, so I'll speak to that. So our ultrasound program at our center, the Indiana Hemophilia and Thrombosis Center in Indianapolis, Indiana, started in September of 2015. So it's been going on for 6 years now. It's a 16-member ultrasound team, and it comprises key members being 4 physical therapists and 2 hematologists. The key members meet weekly when we review scans together, and we also make sure that our current processes are working, and we quality assure each other's scans. We currently have 3 ultrasound laptop machines or devices with a linear high-resolution transducer with the ability to do Doppler, power Doppler imaging. And we also decided to provide handheld ultrasound probes that the outreach nurses can connect to their tablets and as well as for that their phones, because we serve this entire state of Indiana, and we often have patients who live 3 to 4 hours away from the center. So this way we can deploy one of our outreach nurses with a handheld ultrasound to evaluate acute musculoskeletal concerns. At our center, we use ultrasound in 3 major domains or scopes. The first one is for acute painful musculoskeletal episode evaluation as an extra layer beneath our eyes for a beneath the surface evaluation of the joint. This is perhaps the easiest one to actually implement in any center because you do not need very expensive instruments. And I actually was able to train our outreach nurses to assess the joints using the Spanish experience where they do a single view per joint. So we do the posterior view in the elbow, the long axis anterior view in the knee, and the long axis anterior view in the ankle. And we have found that this is a very easy view for the nurses and patients alike to learn in order to evaluate acute musculoskeletal concerns. We do have the ability with our nurses to do a 3-way video call where I can see the images, I can see the probe position, and they can see me so I can guide them for additional dynamic imaging if needed. This is a very easy one to implement, but obviously you need some training and experience with that. The second scope of use in our center is for baseline assessment. And our center is unique with that because we actually have designated ultrasound clinics where we do 6 joint baseline scans of bilateral elbows, bilateral knees, and ankles. And then we do them on every other year basis. That one is difficult to implement, requires a lot of pediatric expertise, teamwork, and time, because each scan can take 30 to 60 minutes to complete. And you also need imaging software to store your imaging and annotate it and score it. So that one is not very feasible in all centers. We're one of the very few centers in the world, and I think one of a couple in the United States who actually does that. And we use Dr. Martinoli's Hemophilia early arthropathy detection ultrasound to do so. And I do recommend other centers, if they are interested in doing that, to collaborate with their ultrasound department and their radiologists. Perhaps the technicians can learn that. They can come to their hemophilia treatment center and do it at the bedside. What you really need is that sophisticated understanding of the patient's status, prophylactic regimen, joint status, and the technology of the radiology technology or the radiologists themselves. The last use, at limited basis, we are not as experienced in that or use it as much as other centers in America, including Dr. Vondrygalski, who has published her experience. We occasionally use it for ultrasound-guided arthrocentesis, and thus far we have not done deposits of viscosupplement, steroids, or a platelet-rich plasma, as you can find in the literature. How our experience lastly compares to the survey, I would say that we do use it for point of care. If we needed to do a full diagnostic ultrasound, we send the patient to the affiliated hospital. Our physical therapists do the majority of the scans, but all scans are reviewed by the physicians. And I would also say that we focus a lot on continued education. We have thus far received over 6 courses in education. We do help educate other providers in the United States, and we make sure that all of our images are stored, annotated, scored, communicate with the EHR because we're making medical management decisions about that. And we also make sure that we are quality assuring each other's work and holding each other accountable.
Thank you very much, Dr. Bakir, for that very comprehensive overview of your experience with ultrasound. Perhaps the next logical question I want to ask is, to what extent is all of your experience transferable to any other hemophilia training center? Essentially, what I'm asking is, how easy is it to implement what you have implemented?
Yeah, and so I will say, I kind of alluded to it in the answering of the first question, but I'll reiterate, the handheld probe is great because it is not very expensive to purchase and you can even lease it. And if you use it for purely, and we are twinned and partnered with Kenya, and our team right now, may they return home safely, they are in Kenya performing their annual visit for the Hemophilia Treatment Center there. We do utilize handheld ultrasound probes in Kenya to help assess target joints, musculoskeletal pathologies. That handheld probe or the laptop probe with some granting funding and or deciding to just merely lease should not be a problem. Where it becomes quite cumbersome, needs time, experience, high quality ultrasound transducers, and imaging software for storage, which would be an additional cost, is going to be the baseline when you are going to do it every year or every other year to perform your ultrasound. Interventional, you can do it with a handheld probe as well, because you're just using it to guide your needle so you don't cause unnecessary iatrogenic injury of a target joint or an arthropathic joint.
Excellent, and thanks again for clarifying that. We do know that in the context of hemophilia, one of the unmet needs is clearly arthropathies, and of course, ultrasound is meant to address that. Do you foresee in the future ultrasound alone being sufficient to address and monitor the musculoskeletal concerns in patients with hemophilia?
My answer would be no. I think that ultrasound is a very promising tool. However, just like MRI is the gold standard, X-ray Patterson scores are absolutely wonderful. I don't think that we should ever, as hemophilia care providers, think of the joint in a very basic way. I think that joint evaluation in hemophilia is a multifaceted evaluation that should be comprehensive and should utilize things like quality of life measures, functional clinical assessment tools like HJHS scores, and so on and so forth. And that is why in our center, actually, despite us having the number of staff that is competent and all of the equipment that we have not done it to the point, we have refused to have it replace the other assessment tools. So we actually do HJHS regularly on our patients. We use, we reflex to full diagnostic ultrasound when we need it, and we do MRIs and X-rays when needed. Ultrasound is very promising, and I think the more that work that we do together and collaborate and standardize and globalize these scoring tools, we will get to understand more and more about ultrasound. However, it does have limitations. It's a superficial musculoskeletal evaluation with particular problem with evaluating the central aspect of the cartilage. Furthermore, there's not consensus right now about ultrasound's ability to detect hemosiderin, to look for micro or subclinical bleeding. It's very operator dependent, and we are waiting, hopefully soon, we will have some access to pediatric atlases that can tell you what is the normal thickness of a cartilage for the different age groups, what is the normal ossification for the different age groups. So I think that it's a very promising tool, but we should always remember clinical assessment first, your hands first, listen to the patient, talk to the patient, and evaluate the joint in a comprehensive way.
Excellent. Talking about the future, the exciting future, what would be the next step and where are you in executing those steps?
Thanks for that. So in the paper, we indicated that our planned next step was to conduct a follow-up meeting, really looking at the global picture of imaging in hemophilia. So not just limited to ultrasound, but also including MRI, with a main focus on establishing common acquisition protocols, interpretation protocols for adaptation globally across different centers. And I'm pleased to report that we have, in fact, conducted that meeting. We did a more formal consensus meeting with a nominal groups process to determine a future agenda and research items for those areas. I'm not going to reveal too much now because we are in the process of publishing those results. And so stay tuned for the findings of that continued work.
Thank you, Sonia. And perhaps it is a pity we can't talk more it remains for me to thank both of you for presenting your work and for giving us more insight into the ultrasound and hemophilia at your center. And we hope that viewers will read the full details of your paper on our site. And Dr. Bakia and Sonia, I hope you'll also be able to publish with us in RPTH in the future. Thank you for watching, and keep an eye out on the next RPTH ReadCap.